Well, thanks for being here, everybody. Welcome again to day 2 of the 2021 Iowa Cancer Summit. My name is Kelly Wells Sittig, and my pronouns are she, her. I have the pleasure of serving as the director here at the Iowa Cancer Consortium, and I'm so happy to be with you all today. Again, there will be a time today where we ask you to turn off your cameras while our presenters are presenting. But if you'd like to share your faces now, we welcome you to do that so that we can, again, all pretend that we're in a big conference room together somewhere. That would be great. And I invite you to introduce yourself to the rest of the folks here by dropping your name in the chat. And if you want to include your organization, if you have one you're affiliated with, and your location in the state, that would be great as well. And while you're doing that, I want to say a really special thanks to all of our event sponsors, especially our platinum and gold sponsors for making the summit possible every year. We truly could not do it without sponsorship. And so I want to say a special thank you to the Iowa Department of Public Health, the University of Iowa Holden Comprehensive Cancer Center, and the Iowa Oncology Society. Thanks for making this event and our collaborations this week possible. We appreciate you a lot. Today's sessions include policy updates. So we've been around the office here, been saying it's policy day. And the fields that we're going to talk specifically about today include tobacco control and genetic counseling. We want to make sure to note too that this evening, after the summit sessions are complete, our friends at the American Cancer Society Cancer Action Network, or ACS-CAN, as I'm sure you've heard it called, are hosting their annual policy forum. We encourage you all to take a look at their program for this free event. So the event tonight is free. And so if you're super jazzed about policy after today's summit session, this is a great way to continue the enthusiasm and the important work through policy that we know can make change. And I know many of us here on the staff will see you there tonight. We're looking forward to it. You can see the great speakers they have lined up there today. A few reminders before we get started with our content. We know lots of you are getting continuing education, so I'm going to give you a little bit of information about that. If you're getting nursing education, I want you to know that the Iowa Cancer Summit was approved for 7.25 contact hours, including 1.67 for today's session. If you are a nurse requesting credit, you should have signed up when you registered. But if you have questions, contact Kelly Rollins, and that's rollins@canceriowa.org if you have any questions. She's great to help with this kind of thing, and we'll make sure you get the credit you need. If you're looking for CHES credit, a total of 7.75 entry-level hours are offered for those that attend the entire 5-day summit, including 1.67 for today's session, and that's approved by the National Commission for Health Education Credentialing. Again, when our presenters are speaking, we'll ask that you turn off your video and mute your sound during the presentations. But when it comes time for Q&A, again, we invite you to show your faces so that we can all interact and have some great conversations about the topics we're going to hear about today. Today's sessions are recorded and will be made available on our website, which is canceriowa.org, after the summit. And now I get the pleasure of introducing our next, somebody who's going to actually introduce our speaker. And I was just saying, how do you introduce someone who always has a blow 'em out of the water introduction for other people, and B, everyone already knows and loves. And so I was asking Dr. Deming, what is something we don't know about you? And it was very hard to come up with something, but now I know Dr. Deming has been to Bacon Fest at least, and potentially he has a closer connection to bacon than the rest of us do in our 6 Degrees of Kevin Bacon game. So I would like to welcome and introduce Bacon Fest expert,
Yeah.
mountain climber, oncologist, and probably most importantly, Vice President of the Iowa Cancer Consortium, Dr. Richard Deming. Dr. Deming.
Well, thank you, Kelly. A fun fact I just thought of. So I'm wearing a pink tie because I am participating in the American Cancer Society Real Men Wear Pink. So it's a fundraiser for the American Cancer Society in honor of Breast Cancer Awareness Month. So that's a pink tie. So thank you. As Kelly said, I'm Dick Deming. I have the honor of serving as Vice President for the Iowa Cancer Consortium. I'm also Medical Director of Mercy One Cancer Center in Des Moines. And like many people, many hats, but another hat I want to just distinguish is I also have the honor of serving on the Board of Directors for the American Cancer Society Cancer Action Network. And that's relevant, related to the speaker I get to introduce. If you want to know anything about tobacco control, just call Kathy Callaway. Kathy is one of the world's experts on tobacco control, and that is not an exaggeration. Kathy oversees the prevention portfolio for state and local campaign team for the American Cancer Society Cancer Action Network. All things tobacco. Kathy's work is 25 years of public health, and she's worked for the American Cancer Society, American Medical Association, Robert Wood Johnson Foundation, funded Smokeless States Project. She was director of the Division of Tobacco Use Prevention and Control for the Iowa Department of Public Health, and also works with the American Lung Association. And I can tell you that in my career of advocating for public health policy around tobacco control, anytime I'm going to go up to the legislators, to the Congress to give a talk, I talk to Kathy, and she fills me in on the latest and greatest. And she is just a policy expert and a real champion. And Kathy, we are so honored to have you here to fill us in on what's going on right now with tobacco control. So my friend and expert, Kathy Callaway.
Well, thank you so much, Dr. Deming. And that was a really generous introduction. I'll start sharing my screen here. Hopefully, can you see it? Is it coming through okay? And can you hear me okay?
Yep, we got it.
All right. Well, it is such a pleasure to be with you all today. Though I do wish, I so wish we were in person. I'm really missing people and missing that collegiality that you have when you are together in a conference room. So, you know, even though I work for ACS CAN's national office, I do still live here in Iowa. I live just between Des Moines and Ankeny, so I'm in Senator Whitver and Representative Gobble's current legislative districts. And there is so much going on related to tobacco and tobacco control right now. So you will probably notice that I'll be looking at my notes as I speak, because it would be awfully easy for me to go down a rabbit hole and not be able to get out. So bear with me if I'm not looking up in the camera. So, so for this presentation, I will, there we go. I think hopefully the slide advanced on your end. It was sticking there for me a minute. But for this presentation, I'm going to provide an overview of current tobacco use rates. I'm going to speak a little bit about evidence-based tobacco control policies. I also want to touch on cannabis and how it is intersecting with tobacco control policies. And then I'll wrap up with what we need to do here in Iowa to reduce tobacco use and reduce tobacco-related cancers in the state of Iowa. So when, you know, despite all the progress that we have made in reducing tobacco use, cigarette smoking still causes about 30% of all lung cancers, and more than 34 million adults still smoke cigarettes. Smoking kills 480,000 people annually, and it costs the United States over $225 billion with a B dollars in healthcare expenditures, and 180 billion with a B in lost productivity annually. And as you know, smoking harms nearly every organ of the body and can cause cancer almost anywhere. in your body. And this chart here is from 2014, and it shows everything from lung cancer down to pancreatic cancer, and the cases and deaths. All of these cancers are smoking related here. And looking at Iowa, we have made a lot of headway. I can remember when I was the director of the Division of Tobacco Use and Prevention and Control for the Iowa Department of Public Health, and the smoking rates amongst high school students were in the 30%. So we have made a ton of headway in reducing cigarette smoking among high school students. However, we do have more than 20% of our youth using e-cigarettes. And we still have 16.4% of adults who still smoke, and that's a little bit above the national average. And we still have, smoking still causes nearly 28% of all cancer deaths are due to smoking in the state of Iowa. And in addition, 5,100 adults die annually every year from their own smoking. And if we don't do anything, if we don't pass any more tobacco control laws, if we don't increase funding for tobacco prevention and cessation, we have 55,000 kids in the state of Iowa that are currently alive who will die prematurely from smoking. So it remains a huge deal for our state. And it's not just the impact on health. There is a huge financial impact of smoking, including $1.28 billion in healthcare costs, and that includes $364.5 million in Medicaid costs. And check out that lost productivity. And we're all paying for it. It results in $989 per household that we pay in state and federal taxes to cover that healthcare expenditure burden. So it's a huge deal. And it's also important to note that these amounts do not include costs caused by secondhand smoke, smoking-caused fires, or other costs associated with the use of other tobacco products like smokeless tobacco, cigars, pipes, and e-cigarettes. So it's a very big deal. And panning back out to look at the national level, this chart shows the trends between 1999 and 2020 for any youth use of any tobacco product. And you will note over here on the right-hand side with between 2017 and 2019, that spike that, essentially erased the progress that we had made in reducing youth tobacco use. That spike is largely attributed to Juul and other USB-shaped e-cigarette products. Now you note that the rate is going down. So that is hopefully good news, but we've also been in the midst of a pandemic, so a lot of other factors. It's going to be interesting to see what happens. And this next slide here this is from the 2020 National Youth Tobacco Survey, and this breaks down the high school use of tobacco products by product. So you can see in 2020, we were at 19.6% using e-cigarettes. And again, these are national, but we can assume that Iowa rates would be similar by product. So on October 1st of this year, CDC and FDA, they just released new numbers on youth e-cigarette use from the 2021 National Youth Tobacco Survey. And what we are finding is, this looks like good news, from 19% down to 7.6. I mean, I'll take it. But the CDC cautioned very firmly that given the survey was done during the pandemic and students completed the survey under different circumstances, the results should not be compared with previous years that were primarily conducted on school campuses. So we'll take this for what it is. And, we're going to be getting more information from this 2021 National Youth Tobacco Survey on the use of other tobacco products. So it'll be interesting to see if other product use went down as well, or if there are spikes in any other product use. But that data will be coming out later this fall. And I would just note that of the students who reported e-cigarette use, almost 44% of the high school students used e-cigarettes more than 20 of the last 30 days, and almost 28% of them used e-cigarettes daily. We know that these products are incredibly addictive, and once young people start, it is incredibly difficult for them to quit. So also this data showed that disposable e-cigarettes are the most commonly used product by high school and middle school students. And you'll note that Juul is no longer the king of the e-cigarette game amongst youth. And this is likely due to the fact that Juul voluntarily pulled their flavored products other than menthol from the market. And so now you can only purchase a Juul that contains menthol or tobacco flavored pods. So, you know, that's one thing that is different from some of these other products. And you'll note that Puff Bar is at the top of the list. And Puff Bar, this is the homepage of the Puff Bar website. I believe this is their banana ice product that they are featuring here on their webpage. And Puff Bar claims that their products are created with tobacco-free nicotine or synthetic nicotine. And they explain that, proudly tout that their products are tobacco-free on their website. And the problem with this is that FDA has not asserted their authority to regulate products that contain synthetic nicotine. Puff Bar doesn't even include age verification on their website, and their products come in all these flavors, and it is not being regulated by FDA. So we are certainly urging FDA to assert their authority over synthetic nicotine. Right now, FDA regulates products that are made or derived from tobacco. Now, whether or not this claim is true, we don't know. But they certainly are making it, and they're proud to claim that they are tobacco-free. So speaking of flavors and flavored e-cigarettes, the 2021 survey also showed that flavored e-cigarettes are still very popular, with 85% reporting using flavored e-cigarettes. And in looking at the flavors that are used, fruit flavors remain the most popular, but note that mint and menthol, and I'm not quite sure why they separate out mint and menthol. Perhaps there's a perception issue that they think people would better understand it breaking it out. But mint and menthol, especially when you combine them together, are still significantly popular amongst youth. And that's why it's incredibly important that if FDA gets rid of flavors in tobacco products, they need to get rid of menthol. If we are restricting or ending the sale of flavored tobacco products at the state or local level, it's incredibly important that menthol and menthol cigarettes are included in that. There's a whole slew of evidence of how the industry has used menthol to target African Americans and other communities of color and other populations that have high smoking rates. And it's unacceptable at this point that we're still allowing that to happen. So let's see. So I mentioned that we'll have more data on other tobacco product use, and hopefully we'll have some more data on menthol cigarettes and flavored cigars as well from that 2021 survey. But in the meantime, the good news is that we know what policies work to reduce tobacco use. And I realize that these are not the, exciting, new policies, but these are the policies that work. Regular and significant price increases on all tobacco products, fully funding evidence-based tobacco prevention and cessation programs, smoke-free and tobacco-free policies, and providing affordable, accessible, comprehensive cessation coverage. This myriad of policies are the ones that we're going to see the return on investment for getting these policies passed, and that's really where we need to stay focused. You're probably aware there was a lot of energy and excitement around Tobacco 21 the last several years, including here in Iowa, but also at the federal level, where we do now have the federal Tobacco 21 law. I will just note that that policy was also supported by Juul and other tobacco companies. Laws that regulate the age of sale have long been on the books and were put on the books by tobacco companies back in the late 80s, early 90s, and it's a space that the tobacco industry loves to engage in. Because what lawmaker can say no to somebody that is saying, we need to keep these products out of the hands of kids? And we don't disagree, but we also know that the majority of kids get their tobacco products through social sources. They're not going into the local convenience store and purchasing them. So while it is a tool in the toolbox, Tobacco 21 is not going to solve the youth tobacco use problem. So off my soapbox on T21 there. So the next few slides are maps that lay out how states are doing, on these evidence-based policies. And these maps, come from our ACS CAN, How Do You Measure Up report. And they are currently in red, yellow, and green, though I realize those are probably not the best colors if you have color blindness issues. So our next report will be in a more easily readable map. But for now, the green colors, they are policies that meet our guidelines. And right now, the average cigarette tax nationwide is $1.91 per pack. So the states that are green on this map are above the national average. The states that are yellow are somewhere in between, and the states that are red are far below the national average. So you can see Iowa, we're right where we like to be, right there in the middle, all comfortable at a measly $1.36 per pack. And this cigarette tax in Iowa was last increased. We increased it by $1 per pack, which was a significant increase and one that we celebrated. But it was clear back in 2007. And what we know about tobacco tax increases is that they have to happen regularly in order for them to be effective. They wear off after time. But increasing the tax on tobacco products has been proven to be one of the most effective, if not the most effective, policy intervention to reduce tobacco use. And, it's really important that we continue to advocate for this to happen. And I know we will hear lots of excuses about, that won't this be a tax on poor people? And, there is, people with lower incomes are very responsive to price increases of tobacco products, as are youth. And people with low incomes are also facing most of the burden when it comes to smoking and tobacco-related illnesses. So we have a responsibility to protect them and to do what we can to reduce tobacco use. This next slide here shows e-cigarette tax rates. And Iowa does not have an excise tax on e-cigarettes, or as Iowa defines them, vapor products or alternative nicotine products. There's a lot of products that I'm going to be showing today that Iowa does not tax if they are for sale in the state. And it's by design. The industry created these separate definitions so they would not be taxed or regulated as tobacco products in our state. But as you can see, we're not alone. There's a lot of states that do not tax e-cigarettes yet. And this next slide makes me so mad. This is about tobacco control funding, and Iowa's clearly not alone. There's a lot of red and even some black, and the black states, they don't dedicate hardly any funding to tobacco control in their states. And the reason this is so frustrating is Iowa pulls in more than $266 million every year in tobacco tax revenues and revenue from the master settlement agreement with tobacco companies. And yet we can only muster the political courage to spend $4 million on tobacco control. I mean, this is just unacceptable. I mean, the whole intent of the Master Settlement Agreement was to reduce future healthcare costs related to smoking. And if you don't invest in prevention and cessation efforts, you're not going to reduce that burden to the state. So as you can see, we are not alone, but this one's really frustrating. We've been, I think we've been hovering around the $4 million mark for several years in Iowa. I think probably since 2012, we've been around the $4 million mark, and that's through this whole e-cigarette epidemic. And, had we had more money to educate young people about the harmful effects of e-cigarettes and the addictive nature of e-cigarettes, we might see different outcomes now. But here we are. And this infographic from Tobacco Free Kids just breaks it down a little bit to show the bigger picture of funding nationwide. States are only spending 2.4% of their tobacco revenues on tobacco control programs. States get a ton of money, billion with a B again. And I know that when we say that CDC recommends that Iowa spend $30 million annually, that sounds like a lot of money, but when you compare that to what states are bringing in and what CDC is recommending, and then you look at what states are actually spending on tobacco control funding, it's unacceptable. And, legislators are not going to just give us the money out of the kindness of their heart. I know appropriations can be boring to work on, but the tobacco industry knows that tobacco control programs, when run effectively, are very effective at reducing tobacco use. And this is certainly an area where we need more resources. And this next map here is Medicaid cessation coverage. And ACS CAN and our partners, such as the American Lung Association, we advocate for Medicaid to provide a comprehensive cessation benefit to all enrollees. And currently, Iowa's Medicaid program does not cover group counseling, and individual counseling varies by plan. And you look at this map, and again, the green states are the ones that are doing it well. And Missouri has the lowest cigarette tax in the nation at 17 cents. You've got Kentucky, you've got South Carolina that are all providing a comprehensive benefit. I mean, if those states can do it, there is no reason that Iowa shouldn't be able to do this as well. So this map here shows statewide smoke-free laws, and unfortunately, Iowa doesn't make this map, and that is because of our casino exemption. Everyone deserves the right to breathe smoke-free air, and it is long past time to close this loophole. This next map shows local and statewide smoke-free laws that include e-cigarettes. And you can see these blue triangles in Iowa, those represent local laws where e-cigarette use has been prohibited in public places or in places where smoking is otherwise prohibited. Unfortunately, our statewide law does not include e-cigarettes. It was passed in 2008 before e-cigarettes were widely popular. So it is time to update the law and add e-cigarettes to it. And I will just note that this is one policy area where we can work at the local level in the state of Iowa. So communities are not preempted. And preemption means when the state law preempts or trumps what localities can do. And currently, smoke-free is the policy arena for us at the local level. So if your community is not represented by a triangle or a circle on this map, this is one thing that you can do at the local level to prohibit the use of e-cigarettes. Things like ending the sale of flavored tobacco products, that is likely preempted in the state of Iowa. So what about federal regulations? So FDA has the authority over tobacco products, and these are just few of the things that we are watching carefully right now. They have the authority to prohibit menthol cigarettes and flavors and other tobacco products, but they have yet to do so. You may have heard that finally, in part in response to a citizen petition that was filed back in 2013, This year, on April 29th, the FDA announced their plan to issue product standards to ban menthol in cigarettes and to ban all flavors in cigars. We know this process will take years, could even take decades. So we are certainly not waiting or banking on FDA to do this. We have quite a few states throughout the country that are working to end the sale of menthol cigarettes and flavored tobacco products. In addition to flavors, FDA also has the authority, and I will just note that FDA has had this authority since 2009. So we've already been waiting quite some time. And it's just a good reminder that nothing happens fast with FDA. So if you're banking on FDA to save the day, you're going to be waiting for a while. But they have the authority to reduce the amount of nicotine in all tobacco products. They cannot reduce it to zero or take it out completely, but they can reduce it to less addictive levels. However, they haven't done it yet, so we wait. And it seems like we've been waiting for graphic warning labels forever. I thought by now we would have graphic warning labels, at least on cigarettes, but FDA acted, Big Tobacco did their thing, filed a lawsuit, and now we wait. So we're still waiting on that one. Good news, FDA has started acting on marketing orders on e-cigarettes. In August, FDA issued the first marketing orders, and as of September 23rd, they issued marketing denial orders, which mean that these products have to come off the market that impacted more than 1 million e-cigarettes. But so far, still no action on Juul or Puff Bar, and many others as well. So in addition to everything that FDA is responsible for, there are several other issues in front of Congress, including a bill to increase taxes on all tobacco products, requiring Medicaid to provide a comprehensive cessation benefit, and funding for CDC to conduct e-cigarette education. So it's exciting to see some of these evidence-based policies getting some traction at the federal level as well. And while we don't know what the long-term health effects of e-cigarettes are, including, if e-cigarette use will cause cancer, we do know that youth who use e-cigarettes are more likely to smoke cigarettes. And I do anticipate that we will begin to see, as these youth and young adults become adults, an increase in our adult smoking rate. And it will be interesting to see, if we can help them quit effectively. I'm a little bit nervous as to, what the future looks like for adult smoking rates. And, it always takes cancer a long time to develop. So I certainly hope that we don't find that e-cigarettes cause cancer, but I personally will not be surprised if they do. And the other thing is, we know that Big Tobacco is relentless. This new e-cigarette promotes its products as, quote, "It will slide you to the deliciousness of 10 energizing flavors with around 3,000 puffs. Just inhale, exhale, and vape like a boss." And as you can see, these products come in very colorful packaging that likely will continue to appeal to young people. And Big Tobacco, they continue to spend billions of dollars marketing their products. And these dollar amounts don't include the marketing of e-cigarettes. They don't have to report that. So we only know what their marketing spend is on smokeless tobacco and cigarettes. So these dollar amounts are just amazing, including what they spend in Iowa annually. And, the industry, you may have heard Philip Morris and others are, claiming that they are all about reducing smoking and encouraging other forms of tobacco use, but we certainly don't see them pulling cigarettes off the market voluntarily. It continues to be big money for states as well as for their pockets in the tobacco industry. They continue to develop new products. They continue to promote harm reduction rather than evidence-based prevention and cessation programs. And as you've seen from the maps, e-cigarettes are nowhere nearly regulated in the same manner as other tobacco products. So if there was a harm reduction solution there, I think we would have seen it by now. They continue to fight us on tax, smoke-free, and funding campaigns. as well as they work to exempt their products from regulation and taxation. And like I mentioned, it's no accident that alternative nicotine products and vapor products are not taxed and regulated in Iowa as cigarettes are and other tobacco products. And also, as I mentioned with FDA, they continue to sue cities, state, and FDA every chance they get. And their goal is to delay regulation as long as possible. The state of California recently passed a statewide law that would restrict the sale of most flavored tobacco products. And the tobacco companies were successful at getting that law upheld and referred to a ballot. And it will be on the November 2022 ballot. I believe the law passed the state legislature in 2020. So 2 years we could have been restricting the sale of flavored tobacco products in California, but now we have to wait to see if the voters in California will uphold the law. It's going to be an uphill battle, but that is what big tobacco does, and they have the money to do it. So it's incredibly frustrating. And then there is cannabis. You've probably heard a lot of conversations happening in Iowa about cannabis and legislation that's been percolating. Well, marijuana is still a Schedule I illegal substance under federal law, but 18 states, 2 territories, and DC have legalized cannabis for adult recreational use. Only 3 states in the country have no public cannabis access program. 27 states and DC have decriminalized small amounts of marijuana. And recently, we have noticed some concerning trends in recent legislation. And these laws are huge. I mean, I've read 300, 400-page pieces of legislation to allow both medical and recreational use of cannabis in states. I mean, you have to think they're creating a whole new oversight. They're creating a whole new tax structure in some instances, regulating the point of sale, regulating the growing of these products. I mean, it's a huge undertaking. And what we are noticing is in recent legislation, there is a lack of public health engagement in the drafting of the legislation and a lack of public health engagement in the oversight of these public cannabis access programs. In many states, the oversight has moved away from public health and under the Department of Agriculture or the Department of Revenue. And this is a trend that we've seen historically happen also with tobacco. So not surprising. And while we fully understand that many legislators are supportive of decriminalizing marijuana possession, I mean, we certainly support that as well. But just as with tobacco control laws, the devil is always in the details. And as these laws are so big, it's very easy to slip in an exemption for cannabis from smoke-free laws, from taxation, and most recently, we're seeing exemptions from flavored tobacco laws. And I'll show some images here in a few slides as to why this is so concerning. Also of note, both Altria, the owner of Philip Morris and maker of Marlboro, as well as British American Tobacco Company, which is the owner of R.J. Reynolds and the maker of Camel and Newport cigarettes, they have invested heavily in cannabis programs. They are ready to seize the opportunity if that Schedule I illegal substance is lifted at the federal level to do business in the cannabis space. And Altria is a member of a relatively new coalition called CPAIR, the Coalition for Cannabis Policy, Education, and Regulation. And on their website, Altria makes it very clear that they want to be part of the process to develop a responsible, legal, and regulatory framework for THC cannabis regulation. And of course they want to be part of the process. If they know how the system works, they can work the system to their benefit. You know, very similar to what we've seen them do with tobacco control laws over the years. So this map here shows state and local smoke-free laws that include e-cigarettes and cannabis. Note again that Iowa's smoke-free law does not include cannabis. So if we ever were to fully legalize marijuana use in the state of Iowa, you could smoke it in any public place that is currently smoke-free. So another loophole that we need to fix when we go in and open up the smoke-free law. And I would note that this product on the right is a Juul, and this product on the left is a PAX. And Juul and PAX were once the same company. PAX products are used for the consumption of cannabis products, and Juul, as you know, is for nicotine and tobacco. PAX kicked off Juul back in 2017 when the hammer was starting to come down on Juul and the impact that it had on youth tobacco use. But given that these products used to be the same company, I can easily see in the future where cannabis would be added to nicotine and tobacco products, and tobacco and nicotine could easily be added to cannabis products. Obviously, they know how to manipulate these devices and manufacture them for the various products that they want to be consumed. And, you know, Big Tobacco, they are always looking out for their bottom line. And if you can addict a consumer, they will continue to come back. And so I don't see nicotine leaving the tobacco industry's space, even if they do become engaged more in the cannabis space. So here's another image of, you know, these products. They're very colorful. They come in a wide variety of flavors. And I just recently learned what Delta 8 is, and it is a cannabis product. And the products on the left are cannabis products, both the upper image and the lower image. The product on the right, same brand, Rare Switch, is a nicotine product. So again, if I can't tell the difference, I mean, I don't envy teachers and parents, you know, that are dealing with the use of these products, because it is very difficult to know what is in them. And, you know, they appeal to kids, I mean, quite frankly. And just because a product is labeled the way it is labeled, we've learned from other e-cigarettes that that doesn't necessarily mean that those labels are accurate. And so until these products are regulated more thoroughly, we're not going to know. But it would be hard for me to tell the difference between the tobacco product and the cannabis product on this slide. So in flavored tobacco laws, we're seeing, as I mentioned, some exemptions for hemp, exemptions for cannabis. And the problem that this creates is if you're trying to remove flavors from the market, it's easy to substitute a hemp product or a cannabis product that is allowed to come in flavors. For example, these wraps on the left could be used around a unflavored cigarette, an unflavored cigar. They could be used to roll your own cigarette. And again, they come in a wide variety of flavors. And these hemperillos are seemingly little cigars made from hemp on the right-hand side. And you'll note how happy they are to promote the very low price as well as their tobacco-free status. So I think we're going to be seeing more and more of these products. And here's just another example, and we're seeing a lot of this. Look at the labeling. These are hemp wraps on the left and hemp cones on the right. But look at the terminology: artisanal, organic, tobacco-free, vegan, GMO-free, natural. I mean, they're basically a health product the way they're being marketed. So it's going to be very interesting to see, you know, how this impacts tobacco use and cannabis use as well, and what the long-term effects. I mean, we need so much more research on the health effects of cannabis, and that's where lifting that Schedule I status would be helpful. Because certainly, you know, at the ACS and ACS CAN, we hear from cancer patients the desire to use cannabis to help with their pain. And, you know, we just need so much more evidence on this. And unfortunately, I think a lot of it is going to play out before we get the research. So Big Tobacco is not the only one, we're not the only ones that know what policies work. I mean, Big Tobacco is all over it as well. And right now, all eyes are on Congress. And I'm a big fan of monitoring what Big Tobacco is saying and what they're asking their constituents to do. So the next few slides here are screenshots that I took from their website just yesterday afternoon. And all of them are focused on mobilizing people to not allow the federal tax increase to pass. So this website here, Own It, Voice It, is owned by Reynolds American Inc. And you would not know that till you scroll down to the very bottom and read the very fine print. This next website, but I would note that you can go onto these websites, you can learn about the issues that they care about. Some of them even have maps. You can click on your state to see what they're monitoring in your state. And it gives you a good sense as to what their messaging is, why they're opposed to tax increases, for example. So I think it's just really smart for us as advocates to pay attention to what they're doing. This next page is owned by Philip Morris, and in their words, it is geared for retailers and trade members. Again, it's tobaccoissues.com, and they're working to stop the nationwide tobacco tax increase. This next page is Citizens for Tobacco Rights. This site is also owned by Philip Morris, and in their language, it is for adult consumers, and it is also reachable on Facebook and Twitter. And the last one here, Voices for Consumer Choice. This is a new one to me and interesting. It's also from Philip Morris, and they say that it has information on legislative issues related to adult consumer choice, and that this website is for adults 21 and over, and you can follow them on Facebook and Twitter as well. And I just point that out because of all the things that are happening right now, the fact that Big Tobacco is focused on defeating a federal tax increase, I think speaks volume. So what should we do in Iowa? And, I mentioned T21. I've heard conversations about increasing fees and penalties on youth and retailers. That kind of stays in that point of sale space. And we just do not have a good history of, getting evidence-based policies passed in that space yet, and especially here in the state of Iowa, especially given the preemption that we have in multiple code sections that prevent us from doing those policies at the local level first. So what we are recommending that we stay focused on policies that we know will work. We need to increase the tax on all tobacco products, including alternative nicotine products and vapor products. It's ridiculous that these products that are addicting our kids are not being taxed at the same rate as tobacco products. And we need to fully fund our prevention and cessation programs. As I mentioned, CDC recommends Iowa spend $30 million annually. We've been hovering around $4 to $5 million for far too long, and all during, we have had no new resources, and we are in the midst of a youth e-cigarette epidemic. It's incredibly frustrating. The most funding we've ever had for tobacco control programs was back in 2008, and we had $12.3 million back then, and it would be great if we could get back to that. With more funding, what we could do, the list is endless, but we could certainly do more public education. We could promote cessation services to those people most in need. We could promote the newly updated lung cancer screening guidelines and make sure that people were getting diagnosed with lung cancer earlier so they would have effective treatment. We could raise awareness of the dangers of the new tobacco products that are coming out all the time. And we could also invest in implementing the state's cancer control plan. And certainly it is time for casinos in Iowa to be smoke-free. No one should have to choose between their health and a good job. And e-cigarettes and cannabis should be added to the statewide smoke-free law as well. And last but not least, we need to ensure that everyone has access to effective and affordable cessation interventions. As I mentioned, right now under Medicaid, group counseling isn't covered, and individual counseling varies by plan. I know these policies may not sound as exciting as flavors or increasing fines on retailers or kids like the industry likes to do, but these are the policies that have time and time again proven to reduce tobacco use and eventually will lead to less cancer. Thank you.
Thank you, Kathy. Great, and I love that you end with this call to challenge us to get up to the State House this next year with 4 specific acts around tobacco control. We have a few minutes. I'm going to ask you the first question, and then we'll go to some of the questions that are in the chat box. So this could be a big topic, but just interested in how to approach it. So as you know, there is a number of scientists and public policy folks that want to talk about harm reduction. And just this year in January, in the Mayo Clinic proceedings, there was a major commentary editorial entitled E-Cigarettes, Harm Reduction and Tobacco Control, A Path Forward. So could you, for the audience, describe what harm reduction is? And then how do we, as open-minded, evidence-based scientists, approach this in a really objective manner?
Very good question, Dr. Deming. So harm reduction is this notion of encouraging, adults that currently smoke cigarettes to get them to switch to e-cigarettes or a less harmful product, a less deadly product. And, as I mentioned, e-cigarettes are not regulated in the same manner that cigarettes and other tobacco products are regulated. So there is a natural path there if people were to naturally switch to a less harmful product. We would perhaps see a reduction in smoking and a reduction in cancer. I'm not sure that we are seeing that right now. There's also a path for e-cigarette companies to submit their products to FDA to be regulated as a smoking cessation device. FDA is not required to disclose products that have been submitted to be approved as a drug delivery device or a cessation device. So we don't know if any company has gone through that process yet. But what we do know is that no e-cigarette has been approved by the FDA as an effective cessation intervention. And so as, evidence-based advocates, we really have embraced supporting those 7 FDA treatments that have been approved for effective cessation. And there is a ton of research that is needed. We don't know what the most effective, how do we continue to help people quit smoking? How are we going to, help youth quit using e-cigarettes? There's a lot of opportunity for more research on, more effective ways to help people reduce and quit using tobacco products. But certainly we just don't have that evidence right now on e-cigarettes. There's a lot of anecdotal evidence, but that concrete evidence that they are effective isn't there yet.
Great. Thanks, Kathy. One of our audience member asked about cannabis smokers, and obviously you talked about the problem that could happen if smoking cannabis becomes legal, and that the way our Iowa smoke-free law, somebody can't light up a cigarette in a restaurant, but they could light up a cannabis product. The difference between smoking cannabis and smoking tobacco, the question is, what about lung cancer? And does smoking cannabis cause lung cancer? And is there a difference in the lung cancer rates between those who smoke tobacco and those who smoke cannabis?
This is an area we need a lot more research on. And this is where that Schedule 1 makes it very difficult for cancer centers to do research on cannabis smoking and just the, illegal nature of cannabis, evaluating people and their long-term use of the product, that's going to take some time. But we do have some states that have resources that have had legalized, California's had legalized cannabis for quite some time. So hopefully we will begin to see more research come out. Anytime, and Dr. Deming, I defer to you as a doctor on this, but anytime you burn leaves and inhale them into your respiratory system, you're going to get particulate matter, and that isn't going to be good. And as so many people are inhaling cannabis through e-cigarettes, again, we don't know what the long-term effects of e-cigarette is going to be for any substance that they would be inhaling through an e-cigarette. So I think this is one area where we really need a lot more research.
Great. Thanks, Kathy. This brings us to the end of the hour. And I would ask Kathy or maybe Kelly if these slides are going to be made available to those of us who do tobacco control work. This is so compelling, your slides, and I'd love to be able to use them in presentations.
I will send them over. Thank you.
Thank you so much. Great presentation. And I'm now going to turn it over to my friend Liz Orton, who will introduce the next speaker. Liz, take it away.
Thank you, Dr. Deming. Hi, everyone. My name is Liz Orton. My pronouns are she and her, and I'm an outreach coordinator here at the Iowa Cancer Consortium. So if you were on yesterday, you would have seen our first kind of session of Meet the People of the Consortium, but it's something new that we're doing this year since we recently reached over 500 members in the consortium, which is the first in our history. So we will be meeting some of our members today. Up first is Jackie Kale. And so Jackie, go ahead and take it away. You can share your screen if you want to, or whatever you need to do.
Thank you, Liz. I actually don't have any slides, so I'm just going to be talking. Hello, Cancer Consortium members. My name is Jackie Kale. I am the Iowa Grassroots Manager for the American Cancer Society Cancer Action Network. Thank you for having me today. I'm excited to share why the consortium has been a wonderful partner for myself and ACS CAN. As you've heard earlier, ACS CAN is the advocacy affiliate for the American Cancer Society the American Cancer Society. We are a nonprofit organization that advocates for cancer fighting policies and legislation at the state, federal, and local levels. In Iowa, we work with hundreds of volunteers on access to healthcare issues, protecting Medicaid, as you know, tobacco control issues, radon legislation, and much more. As a grassroots manager, I get the privilege of helping our volunteers navigate the complicated legislative process and teaching them how to share their stories with their elected officials. My day never looks the same, but you can typically find me interacting with our volunteers and our partner organizations. During session, which is January through April, I'm working with our government relations director, tracking bills, and working with our volunteers to advocate for those cancer fighting priorities. Another major aspect of my job is coalition building. ACS CAN partners with a variety of different health organizations, the American Heart Association, the American Lung Association, Iowa Department of Public Health, and of course the Cancer Consortium, to name a few. One way we build our coalition is through the Cancer Consortium's Policy Committee. During session, the Policy Committee meets each month to discuss the priorities within each organization. It's a wonderful way to hear what other organizations are working on and see if there's any room for collaboration. I started off my career at a public affairs firm in Des Moines, and then I spent a year working on a campaign. It was through both of those positions that I learned the importance of advocacy and the true impact that a story can make. That's why I decided to switch gears and ended up as a grassroots manager at ACS CAN. By far the best part of my job is the people I get to interact with every day. Our volunteers are rock stars and so passionate about making a difference for future cancer patients, survivors, and their caregivers. I think it's fair to say that they keep me going when things get tough. As you know, it can take years for even the smallest piece of legislation to pass. Sometimes it does get a little defeating, but whenever we feel in a rut, the volunteers and the mission are the things that keep me going. Passing significant legislation will impact thousands even hundreds of thousands of cancer patients. And that takes time, and our volunteers are relentless. For example, it took 10 years for the Removing Barriers to Colorectal Cancer Screening Act to pass. Year after year, our volunteers advocated for this piece of legislation at the federal level, and it finally passed at the end of 2020. It was truly inspiring to watch our volunteers never give up. Only took 10 years. Over the next year, my goal is to really grow our advocacy team. It has been an adjustment learning how to advocate in a virtual world versus doing it in person. And it's definitely been a little bit harder to grow the team strictly being virtual. Fingers crossed that next year we can be together, but for now we're still going to continue fighting in the virtual world. But the only way we can continue to make a difference is by having a large and very diverse group of volunteers and advocates sharing their story at the State House. Whether that's attending a day at the Capitol, sending an action alert to your elected official, posting or sharing your story on social media, all of it makes a difference. Before I leave you, please consider becoming an advocate. If you're not sure how or new to the advocacy process, please reach out. I'd love to get to know you and teach you how you can share your story and how your story can really make a difference. And then I also can't leave without my shameless plug for ACSCAN Iowa's Policy Forum this evening. It's at 5:30 p.m. and we're going to be celebrating 20 years of accomplishments with ACSCAN and discussing the past, present, and future of tobacco control in Iowa. I hope you can join us. Thank you to the Cancer Consortium for having me. I will turn it back to Liz.
Thanks, Jackie. All right, and then now I'm going to introduce Dr. Sneha Phadke, and she will give a little same kind of introduction for herself and take it away.
Thanks, Liz. And thank you for asking me to do this. As Liz said, I'm Dr. Sneha Phadke. I'm a breast medical oncologist at the UI Holden Cancer Center. So I see patients in the clinic who have breast cancer or who are at high risk of developing breast cancer. And then as part of my job as a faculty member, I also teach. So I teach at all levels of medical education, from medical students through residents and fellows. And then I also lead several research projects in the realm of breast cancer and other types of supportive cancer therapy. So I decided to go into oncology because I found it to be challenging, but also rewarding in many ways. The science is really quickly evolving, and even in just the past 8 years since I started my fellowship, there have been major changes and improvements in how we treat and diagnose breast cancer. And I've seen patients actually directly benefit from that research. And that's really exciting because, I look back on how much has changed in the past 8 years, and then I think of all the potential changes and improvements to come in the next 8 or 10 years, which will make this disease even more treatable and hopefully increase rates of cure and also increase the quality of life of cancer patients. So for me, a typical day kind of depends on the day. So there's some days I'm seeing patients in the clinic, and then there's other days that I'm doing research or doing teaching. So with my research and kind of academic pursuits, I work with several different collaborating organizations and groups outside of UIHC. So obviously I work with the Iowa Cancer Consortium, and I have a leadership role within the consortium as co-chair of the Research and Clinical Trials Working Group. And then I also did an 8-month capstone practicum project with the consortium as part of my master's in public health degree, which I finished in 2020. So also through that degree I earned, I've had the pleasure of working with and getting to know colleagues at the UI College of Public Health. And then outside of Iowa City, I work with a few patient advocacy organizations like Beyond Pink. And then with my research, I work with a group called the Big Ten Cancer Research Consortium, which is an awesome organization where the Big Ten University Cancer Centers come together to collaborate on clinical trials and other cancer research projects. So that's also something that I enjoy, and I'm actually the co-chair of the Breast Cancer Clinical Trials Working Group within that organization. So I wanted to there were a couple interesting questions on here I thought I would answer. So one is, when I feel stuck in a rut, what is one thing or place that can get me out of it? So when I feel stuck in a rut, usually I exercise, especially running or some other type of cardiovascular exercise that really pushes me, because that seems to kind of clear my head. Also taking a nap or sleeping in general can help, or catching up with an old friend, something like that. And then the other one I wanted to answer was, what 2 to 3 books have had the biggest impact on you, or that I read most often? I think there's 2 books which have professionally had the biggest impact on me. The first one is Being Mortal by Dr. Atul Gawande, which I would highly recommend that one. And then What Doctors Feel by Dr. Danielle Ofri. And if you're a physician, I would highly recommend that one. Both have really made me just stop and reflect on my career and how I approach patient care, and also kind of how I take care of myself, working in a field that can often be pretty emotionally demanding. So one thing that I see as a trend right now, and also one thing I'm kind of working on myself, is addressing burnout, primarily among physicians and oncologists, since that's what I do. But burnout in healthcare professionals, unfortunately, before the pandemic was relatively high, but in the pandemic now, it's really unfortunately kind of soaring. So I think we have to act pretty urgently if we want to maintain our healthcare workforce and take care of each other. So I'm just starting small, within my own division, and helping to create some a curriculum and some other programming to sort of help our own physicians and healthcare providers with resilience skills and wellness, and also advocating on a little bit of a larger level. So I think that's something that's very important right now. So that's all I have. Thank you so much. It was great talking to everybody.
Thanks, Sneha. So now I'm going to introduce, I'm going to introduce someone to introduce our next speakers, but please welcome Iowa Cancer Consortium board member, Sarah Zeidler. Hi, Sarah.
Hello, good afternoon, everyone. As Liz said, I'm Sarah Zeidler, and I'm the Executive Director for the Stoddard Cancer Center in Des Moines. I'm also an Iowa Cancer Consortium board member, a new member, and then also I'm a longtime Tri-Chair of the Policy Committee. Thank you guys all for being here today, and I'm really pleased to introduce our next speakers. Our final session today is focused on genetic counseling, and we'll be hearing from Dr. Colleen Campbell and Jillian Hooker. Dr. Colleen Campbell is the Director of Genetic Counseling Operations for the University of Iowa Hospitals and Clinics, overseeing the administration, standardization, and continuous improvement of genetic counseling operations across the health system. Recently, Dr. Campbell led the successful Iowa legislative effort to license genetic counselors in Iowa, and is involved with federal legislation for Medicare recognition of genetic counselors to improve patient access to genetic counseling services. Dr. Campbell is also Assistant Director for the Iowa Institute of Human Genetics, a statewide initiative focusing on educating patients and clinicians about how clinical genetics can improve medical care, and on bringing precision medicine, principally by offering more and better genetic tests to the region. The focus of her work is to integrate and improve patient access to precision medicine throughout healthcare based on her unique perspective and understanding of the interactions between the lab, providers, patients, legislature, and the healthcare system. As an active member of the genetic counseling community, she serves as Secretary-Treasurer of the National Society of Genetic Counselors and serves as a member of the American Society of Human Genetics Program Committee. Dr. Jillian Hooker is the Chief Scientific Officer of Concert Genetics, a health IT firm based in Nashville, Tennessee. She is the immediate past president of the National Society of Genetic Counselors and serves as an adjunct associate professor with the Vanderbilt University Medical Center, leading the research arm of the Vanderbilt Genetic Counseling Training Program. Applying her background to molecular and clinical genetics, genetic counseling, and behavioral science, she's committed to overcoming the barriers to effective translation of genome science at the patient, provider, and system levels. As a researcher in academic and government settings, Jillian has worked with numerous transdisciplinary teams on the front lines of genomics, developing and evaluating methods for delivering information to patients and their providers. Having served as the Associate Director of a genetic counseling training program, she also brings significant experience in genetics education and outreach. Jillian completed her doctoral degree in molecular, cellular, and developmental biology at Yale University and her master's degree in genetic counseling at the Johns Hopkins School of Public Health, National Human Genome Research Institute Genetic Counseling Training Program. She grew up in Kalamazoo, Michigan, and attended Kalamazoo College. Everyone, please welcome our presenters.
Thank you, Sarah. Thank you guys for having us speak today about genetic counseling. I know Jillian and I are really excited and really grateful for the support from the Iowa Cancer Consortium with the genetic counseling policy efforts that we have both at the state level as well as the federal level. So let me share the screen. Okay, so my disclosures are here at the bottom. And what we're going to talk about today is first, how do you identify genetic counselors, how do genetic counselors improve patient care? We can also talk about how to identify genetic counselors to work with your patients, summarize the current state of genetic counseling in Iowa, understand the value of genetic counseling to Medicare beneficiaries, recognizing issues of access disparities in the field of genetic counseling, and then talking about the importance of telehealth in genetic counseling. So just for some background and to make sure we're all on the same page, I think this group's probably pretty savvy with regards to genetics, but genetic counselors that we're going to be speaking about today are individuals who have graduated from an accredited graduate program. There's about 50 of these in the nation right now. And upon graduating from one of these programs, they are eligible to sit for the American Board of Genetic Counseling Board exam. So these are the board certified genetic counselors, and that'll be the focus of our conversation. Genetic counseling can be conducted by others as well, and we see that in the state, such as nurses and physicians. But genetic counseling is really the process of helping people understand and adapt to the medical, psychological, and familial implications of the genetic contributions to human health and disease. And I think often people think about us as just educating individuals about, modes of inheritance and genetic testing options, but that counselor part of our name is really important in helping people adapt to this information so that they can make informed decisions. What do? We interpret family and medical histories as well as genetic test results. We educate not only patients, but also other medical professionals about disease risk, management, prevention and testing options. Jillian's company has shown us that there's 14 new genetic tests launched every day in the United States. So this is a really rapidly changing space, and it's hard for providers to keep track of it. And that's where the genetic counselor can come into play. And then we also counsel patients so that they can make informed decisions and also cope with the emotional aspects of the genetic condition or diagnosis. Genetic counselors are actually trained as generalists, and this is really important to keep in mind if you're looking to hire a genetic counselor and you're worried maybe they haven't had tons and tons of cancer experience. If it's a new graduate, they've had a cancer rotation, you want to find someone who's passionate about cancer, obviously, but they'll specialize on the job. And our two largest specialties in the profession are both prenatal and cancer. And in Iowa, we have additional specialties more than just what's listed here on this slide today. So there's been a lot of research about genetic counseling and the value of genetic counseling. And so next I'll talk about, some of the benefits that research has shown to patients as well as providers, as well as hospital systems. So with patients, there's improved knowledge and increased satisfaction. But I think what's really important in the setting of cancer is an increased adherence to medical management. So following up with those, mammograms and colonoscopies and all the screening recommendations that you provide patients is something that research has shown patients who have seen a genetic counselor are more likely to follow up and adhere to the physician's medical management recommendations. For physicians, I like to talk about genetic counselors as practice expanders. So we have longer appointment times, and we really delve into that those psychosocial aspects that influence what decisions people make with regards to not only genetic testing, but also the adherence to screening recommendations. And so we're able to help, take on those heavier emotional conversations so that the providers can see more patients. One of the questions we get asked about a lot in Iowa is about how do we identify good genetic testing labs? There's a lot of labs out there, and Jillian can probably give a lot of statistics on this, but there are some that we would recommend over others. And, if you ever have a question, we're happy to help you identify what lab might be helpful for you and your patients. And then for hospitals, obviously the integration of precision medicine throughout healthcare is something that all hospitals are working towards. And so we can really help in that implementation of precision medicine. We also have preliminary data from the University of Iowa in our Holden Comprehensive Cancer Center that genetic counselors, specifically working in breast cancer, can generate downstream revenues for genetic counseling as well. So next, we're going to talk about the current state of genetic counseling in Iowa. And to do this, I want to give a little bit of background on the history and where we've come from, so you can understand and appreciate where we are today and where we want to go. So in November 2013, our vice president of healthcare asked me to start a graduate program. And at the time I told him no. And the reason I said no was there was only 5 genetic counselors in the state of Iowa. That included myself, and I was doing a postdoc at the time in molecular genetics. And there was actually no genetic counselor specializing in cancer or prenatal, which, if you recall, those were the 2 largest specialties in the profession. So I knew there would be no way that we would get accredited have an accredited graduate program with the shortage of genetic counselors that we saw in the state at the time. So I got called, it's like getting called to the principal's office and explained, why there was this shortage, and was charged with writing a business proposal on how to fix the shortage. And so I spent the next year looking into what was going on in Iowa with regards to genetic counseling and putting forth a proposal on how we could fix this, which I gave to our leadership in 2014. And in that proposal, there were 3 key strategic challenges that were identified. It was recruiting genetic counselors to Iowa, retaining genetic counselors in Iowa, and then creating that graduate program that the administration had requested. And when we looked at all of these in more detail, they really came down to infrastructure and satisfaction issues. And so if we could address those, our hope was that we could then recruit and retain more genetic counselors and eventually have that graduate program. And this was a figure that was in that report. And this was the figure I think that was really the game changer for our administration. So what you're looking at is a map in the United States of all the board certified genetic counselors, and looking at the number of board certified genetic counselors per million residents. We knew that in 2014, this was an overestimate at the time for the state of Iowa, because when we looked at the database, we knew all the names and we knew people had moved away, some had retired, but for consistency, we used the same database for across the nation. So we know that this number was actually an overestimate, but that what our leadership saw was that we were falling behind with being able to provide these services to our patients. Oops. There we go. So we had to work on recruiting more people here. And there were a lot of things that we needed to address, such as our salaries and job satisfaction, the structure of how genetic counselors, who they reported to in the hospital and how they were structured within the hospital, and allowing them to specialize more, which was something they wanted. But one of our other hurdles to recruitment was licensure. And so why licensure was important was that licensure really would allow genetic counselors to work at the top of their scope of practice. A lot of people think of genetic counseling and genetic testing as going hand in hand, even though there's more that we do than just genetic testing. But without licensure, we actually weren't legally allowed to order a genetic test, which seems kind of crazy. And so we wanted to make sure that genetic counselors could work at the top of the scope of practice so that we could recruit them here. It would also help provide recognition and respect as healthcare providers, define the minimum standards for education, title protection was really important. At the time, there were a lot of people who would say they were a genetic counselor, but they may just have an undergrad degree in biology. And then our recruits were asking about licensure because they understood that in order to work at the top of the scope of practice, they needed to be licensed. So it was something we knew was going to be a challenge. We also were getting a lot of calls from hospitals that were trying to identify who was actually a genetic counselor because they were trying to hire genetic counselors. And so licensure, by enabling that title protection, would help hospitals be able to hire genetic counselors as well. I was not a public policy person prior to this. Thought licensure would be pretty straightforward and easy. Our administration told me it would be this way. Realized in 2016, as you guys I'm sure are aware, it was a little more complicated. And then by the end, realized it was actually pretty complicated to get the legislation passed. But happy to say, you know, we were able to get there. When we were obtaining licensure for genetic counselors, there were a lot of concerns that came up. Genetic discrimination and privacy was one of the concerns that came up one year and killed the bill in 2017. There were also the standard scope of practice concerns. In the state, there was an anti-licensure sentiment. They were trying to actually de-license a lot of healthcare providers at the time. And then we were just an easy, you know, we were a small group, and so it was easy for us to be a little political pawn in some turf battles that were happening that are pretty standard, and I'm sure you guys are familiar with at the state capitol. We were very fortunate that we had grants from the National Society of Genetic Counselors that enabled us to work with Cornerstone Government Affairs in Des Moines, and specifically David Edelman and Sarah Allen were leading our efforts for obtaining that licensure. And I've never been so proud to be 24th, but we were 24th in the state, 24th in the nation to license genetic counselors. The bill was SF 2228, and it actually went into effect in January 2019. And the thing that I love about this picture is that people are actually cut off, and that's because there was such broad bipartisan support for this bill that we had party crashers, and they couldn't actually shut the door to the governor's office because there were so many people trying to squish into this room. And we actually only had one no vote in the House and one no vote in the Senate, which I think shows that, you know, genetics is, it does impact everybody. And so we were able to really generate this broad bipartisan support, which will be important as we talk about the federal effort as well. So we have improved, and I'd say if we redo these numbers now, that it's even better. But I often get asked, you know, what else do we need to be doing, and where are these people located? So if we look at this, actually, as of today, there's 280 genetic counselors licensed to practice in Iowa, which is so exciting, given that we came from just 5 genetic counselors in the state. Majority of these individuals actually don't live in Iowa. They work for genetic testing companies or telehealth companies, but they're licensed to practice here and they can speak to patients throughout the state. There are 33 genetic counselors that work and live in Iowa, and 11 of those actually specialize in cancer. Where those individuals are located, we have Holden Comprehensive Cancer Center has clinics not only in Iowa City, but also in the Quad Cities. Our friends in Ames also have a genetic counselor. And then we have now multiple genetic counselors in Des Moines, which is really exciting as well. And then our friends out in Sioux City at Junine Island Cancer Center are working with genetic counselors in Nebraska to also start a genetic counseling clinic in Western Iowa as well. So this is really exciting to see the growth in the state. So I often get asked how many genetic counselors are needed, and you know, how much further do we have to go in Iowa? And so there was a workforce study done in 2016 that was looking at how many genetic counselors do we need. And at the time they said you need 1 full-time clinical patient-facing genetic counselor for every 100,000 or 75,000 individuals. So we know some of those genetic counselors that are working in Iowa are actually working for the testing labs. And then like myself, and I don't see patients all the time. And so we do have room to grow. Also, this study was from 2016, and I think you guys are really well aware that in the cancer space, there's been so many more gene-based treatments and mutation-based treatments that have evolved in cancer. And so I would say that this number, I would definitely lean towards the 41.8 FTE, if not higher, based on the advances in precision medicine since 2016. So looking to the future, I would say that the future looks pretty promising. As you heard, I also am the assistant director of the Iowa Institute of Human Genetics, and one of my jobs there is to oversee our education division. And we have a lot of education events. We have a career series with 3 key events. One is on just general careers in education. We've also, or in genetics, I'm sorry, and then careers in genetic counseling, and then also careers in big data and bioinformatics. And to date, we've had over 700 students, advisors, and educators from the state of Iowa and our neighboring states who have attended this career series, which is really exciting. We also have a summer internship program, which has been tremendously successful. We've seen a tremendous amount of growth in the number of applicants in this program. And to date, we've hosted 24 interns. Sadly, we haven't been able to have this program the last 2 years due to the pandemic, but we're hoping by this summer we'll be able to have the internship again. One of the things we're most proud of with the internship is that 58% of our interns are from underrepresented populations in genetic counseling, which includes rural students from rural backgrounds, which as Iowans, we can really appreciate the need for individuals from rural backgrounds to be incorporated into the healthcare system. Our interns have a very high success rate of matching into graduate programs. And this program was developed as part of our long-term recruitment strategy. And so we now have 5 former interns that are licensed genetic counselors in Iowa. And 3 of those individuals are working in the Holden Comprehensive Cancer Center. So we're very excited to see these students go off and be successful and then return to the state and work. In order to help more students, we developed an online professional development series free of charge. And again, we are really proud of the fact that a lot of these students are from underrepresented populations in the genetic counseling profession. We believe this number is actually higher than 40% because we have not yet analyzed all the rural zip codes of these participants. So this is probably a little bit higher. And our goal with this program was to provide another opportunity for students to learn about genetic counseling and help them get into graduate school and be successful as genetic counselors. So again, we could someday not only help grow the workforce here in Iowa, but also nationwide. Students in this program, if they attend 17 of the 18 lectures, they can receive a certificate of completion. And when we do follow-up surveys of those individuals who receive a certificate of completion, they have a very high success rate with the graduate program match process. So this is very, very exciting. In 2017, we actually had access to the data of the students that had applied to graduate school and been accepted to graduate school for genetic counseling. And we saw that 29 of the 354 students that year were from Iowa, which was really impressive given the size of our state. So we were really excited about this. So now I'm going to talk about telehealth. What you're looking at here is a map from the first year that we started. We had implemented an EPIC department specific to genetic counseling that enabled us to really track data. And at that time, we had seen patients at the University of Iowa from about 80 of the counties plus 31 other states. And what you're looking at next, and this is a really busy heat map and that they actually just have provided me, but what you're seeing is majority of these patients are coming from Eastern Iowa. And when we start looking at the northern and western part of the states, we're looking at single digits. And so we know there's still a lot of patients that are not receiving genetic counseling services, and obviously access is an issue that we believe that telehealth can help us resolve. Our friends in Des Moines obviously have picked up more patients as well, but these numbers are unique just to the University of Iowa. I don't have access to the Des Moines numbers, but I would hope that we'd see a little bit better coverage here in the central part of the state if we had that data as well. We know our friends in South Dakota are helping up here in Northwest Iowa, and our friends in Nebraska are helping as well. But we still believe that there's a lot of patients that don't have access to these services. So when hospitals are thinking about hiring genetic counselors, I often get asked, this is great, but how do we pay for them? And so that's, I think, one of the biggest hurdles we have in front of us. at this point. So currently at the university, we're having genetic counselors bill a facility fee. Obviously, that doesn't cover the cost entirely. But we're beginning to start working towards billing a professional fee. And one of the things that'll really help us, I think, is CMS recognition, which you're going to hear about from Dr. Hooker next. But I can say for the University of Iowa patient data, CMS or Medicare is the third most common payer for our genetic counseling patients. And so I would anticipate a similar pattern with other health systems across the state. So in summary, genetic counselors can aid in the delivery of precision medicine and help improve the quality of care and decrease healthcare costs. We've grown the workforce in Iowa through a series of infrastructure and satisfaction initiatives in a time of really high demand. We believe the growth of this workforce will improve patient access to precision medicine. And we know that there are Iowa students that are enrolled in graduate programs across the country who would like to return to Iowa and work as genetic counselors. And so we need to work on increasing those job opportunities so that way, and policy will be key in creating those job opportunities so we can recruit these individuals back to the state to serve our patients. There are a lot of people who have been involved with this revamping of genetic counseling in Iowa, and I can't thank everybody enough for this. I'm happy to answer any questions you have either later today or if you want to follow up after the conference. I'm also happy to talk to anyone at any time about genetic counseling in Iowa. So with that, I'll turn it over to Dr. Hooker.
Thank you. Thank you. Colleen, you did get a few questions in the chat. Are we going to answer them at the end or?
Sarah, would you like me to answer them now or at the end?
You know, it might be good to answer at least one of them now, just so everyone, they're kind of crucial questions, I think. So specifically about, do you work with individuals who are interested in undergoing genetic testing or who have undergone testing, or can you just like walk through the process a little bit?
Yeah, definitely. So within the cancer space, we'll often work with people who either have been diagnosed with cancer and need genetic testing in order to help inform on their treatment options. We also work with individuals who have not yet been diagnosed with cancer, but have maybe a family history or other risk factor that puts them at a higher risk of having a genetic form of cancer. And so we talk about, is genetic testing appropriate to them or not? And then help them navigate which is the best genetic test. There's so many genetic tests out there. And so making sure we're getting the right test for that patient to answer the question about that patient's cancer. Which is really important because often insurance will pay, we can get insurance to pay once, but if the wrong test is ordered the first time, it's a lot harder to get insurance to pay for the correct testing. And then once somebody has genetic testing, if they elect to have it, or even if they don't, we talk about based on your family history and or your genetic test results, what would be the appropriate screening options there's published guidelines for based on your risk factors. So that's, the process there. Jillian, feel free to jump in too.
Oh, no, I agree. That was sort of a pressing question to cover off on. So
yeah. And then I think there's one more, if you don't mind answering, about what is genetic discrimination.
Yeah. So there was a law, the Genetic Information Non-Discrimination Act, that was passed in 2003 or 2008. I'm totally drawing a blank right now. But basically, it's a federal law that says, based on your genetic information, and in this case, we're talking, I always say like big G. So we're talking about your family history, genetic test results, anything like that. You cannot be discriminated against for employment discrimination or health insurance discrimination. It's important to understand, though, people can use this information to discriminate against you for, life insurance, long-term care, or disability insurance. There's also exemptions to it. So if you're in a small company that's 15 people or fewer, you're not protected by the federal law. The military is not covered by that law. They have different laws. And so this is something that genetic counselors often talk to their patients about and work with it when a patient's working through, should I have genetic testing or not? And what's the best time in my life to have this testing? We will talk about this law and, do you have your life insurance in order, different things like that. Or are you the right person in your family to have testing? And so this law has been really helpful in that prior to that law passing, patients would sometimes have to pay out of pocket so that their genetic test results didn't end up in their medical records. So insurance companies couldn't have access, or employers. And so this has really helped make genetic testing more accessible to more individuals. Jillian, feel free to add anything on that one too.
Yeah, no, I think just to add that it's such a nuanced piece of this whole picture, and it can be really helpful and can require often at times when patients are making decisions, folks who have background in the details of this and the difference between like group and individual insurance and where that comes into play can be really complex. And so we're having a lot of those conversations with our patients as they think through what are the right choices for them and for their families.
Yeah. And I saw another question pop up about genetic testing and family history. So just because you have a family history doesn't mean we have a known genetic mutation that can explain your family history of cancer today. But genetic counselors do heavily rely on family histories in helping them select what would be an appropriate test for your family. In addition, who's the best person in the family to be tested? Sometimes the person who wants to be tested might be, let's say, a daughter of an individual who had breast cancer. And really, if the individual who had cancer is still alive, that's the person we'd want to test first, because that result will be more informative. If the person who had cancer tests negative, then we know we just haven't identified the gene, or that it's not a genetic form of cancer. And so then we wouldn't want to move on and test an unaffected family member, right? And so it really helps. We use the family history a lot as a tool to help us identify the best genetic test and the best person to receive that test in the family. So
yeah, and then I think the other thing I would add on to that is just the way that, like, as Colleen said, this market and the space is changing so rapidly. So even folks who maybe had genetic testing 10 years ago, it looks dramatically different now. And so, and our knowledge changes, I think, as everybody is probably well aware, because this is certainly true across the entire oncology space, that our knowledge is changing so rapidly. And so these are the sorts of things that I think we're increasingly starting to see as lifelong conversations for individuals and families.
Mhm. All right.
Sure. So I was just delighted to be invited today are you seeing the right screen? No.
We're seeing presenter mode.
Okay. I feel like it's like rolling the dice for me.
I know.
Have it set up, and then anyway, but just delighted to be with you all today to talk a little bit about the national perspective on the federal legislation for genetic counseling and efforts to improve access to genetic counselors. And it's really fun to be able to tag team with one of my favorite people, Colleen Campbell, on this and bring you all like both approaches sort of nationally and locally and be able to tie it together in this way. So mostly I'm going to be focused on the federal bill, the Access to Genetic Counselor Services Act, give you background on the bill, tell you a little bit about where it is right now. And I'm really in this capacity speaking as the immediate past president of the National Society of Genetic Counselors, which is really the leading advocacy organization in our country for genetic counselors and is leading the effort around the federal bill. Other relevant details to mention that really don't have a lot to do with what I'm going to say today, but in the interest of transparency and disclosure, I am the Chief Scientific Officer of Concert Genetics, a health IT firm, and serve on the board of a company called My Gene Counsel, which provides also technology tools for patients who've had genetic testing. But far and away, one of my greatest passions is talking about the field of genetic counseling and the things that are happening in our field, and more than anything, the growth that we've had. I think this is really one of the greatest sources of pride of genetic counselors right now is that we are one of the most rapidly growing health professions across the country. And what you're seeing here is a graph that was provided by the American Board of Genetic Counseling with the year-over-year growth in certified genetic counselors. And as of just a couple of weeks ago, we had 5,921 genetic counselors. Now the summer board cycle is over, so we have to wait until the winter to hit 6,000, but I think that's gonna be a really good number when we do. And we've just really had tremendous success in building new programs, growing our programs across the country, and even more so, and I think this speaks to a lot of the efforts at the University of Iowa, like growing interest in the profession. We had in this last cycle, we had over 2,000 applicants to genetic counseling programs nationwide, and that was for about 500, 550 slots. So we have far more demand for training in genetic counseling and then we currently do have slots. But I think like it's a huge asset to have captured the imaginations of people who love genetics and who love innovation and who want to serve other people. It's sort of an embarrassment of riches, I guess, when it comes to the applicant pool. And so there's a lot of room to grow and a lot more possibilities. And I think there's been a lot of discussions over the years and questions about, do we have a shortage of genetic counselors? And I think increasingly it's hard to say we have a shortage, both because there are pretty extreme upstream barriers and bottlenecks for people getting to genetic counselors in the first place. And also because we're finding, a lot of new methods to reach patients through telehealth, through genetic counselors who work with labs. But I think it's clear that there are localized shortages across the country. And this is a really interesting study that was just recently published by researchers at AstraZeneca and Merck, where they did a geospatial analysis of access to genetic counselors. And what you see on the top in the black and white are all the locations of the genetic counselors across the country. And below that, you see a heat map of distance to genetic counselors, how far someone would have to drive to reach the nearest genetic counselor. With the folks in metropolitan areas being 15, 20 minutes, but the rural population being significantly further to the nearest in-person genetic counselor. In rural populations in the United States, only about 6% of people who live in non-metro areas are within a 30 minutes drive of a genetic counselor. So it's a significant burden. And I think also, as Colleen says, really speaks to the importance of telehealth and access to telehealth. And this is just geography. I think you can look across a lot of other sociodemographic variables and identify even more disparities in access to care. So part of the reason I think we see this concentration of genetic counselors in metropolitan areas and even siloing of genetic counselors within academic medical centers is a story about billing and reimbursement. And this is data from a master's student that I worked with, Eric Chaku, did a study where he analyzed survey data from genetic counselors. Our National Society surveys genetic counselors every year and gets over a 50% response rate every year. And so it has pretty solid data about the profession, trends in the profession, how folks are practicing, and in this particular case, how folks were billing for their tests. And he saw that there were just dramatic variations across the country in the percentage of genetic counselors who were billing for their services. I was doing pretty well, so y'all should feel pretty good about that. But some states, it's really, really low, the percentage of genetic counselors billing for their services. And he dug into some of the reasons why and what were the predictors of genetic counselors billing for their services. And the number one predictor he saw was practice area, that genetic counselors who were practicing in a prenatal, OBGYN environment were much more likely to be billing for their services than genetic counselors who were practicing in a cancer setting or a pediatric rare disease setting. And one of the hypothesized reasons that we'd like to dig into further was that in the prenatal setting, a lot more of the people who are seeking genetic counselors are commercially insured, which is also where reimbursement for genetic counselors tends to be a lot better. In the cancer setting, you have a much higher percentage of patients who are on Medicare, and in the rare disease setting, a lot higher percentage of Medicaid patients. And so, and this anecdotally is what we hear from a lot of hospitals and clinics, is that they're not establishing billing, they're not credentialing their genetic counselors because of the significant percentage of their population that they can't bill for. And the main reason they can't bill for it, this is my lead up into the bill, they can't bill for it is because genetic counselors are not currently recognized as providers in the Social Security Act. So in order to bill for Medicare, you need to be recognized as a provider explicitly within the Social Security Act. And so that is quite literally what the Access to Genetic Counselor Services Act does, is it asks that genetic counselors be added as a billing provider under Medicare. And this has happened for many, many other providers, PAs and NPs, physical therapy have gone through similar bills to be added to the Medicare Act. And so that's what this bill would do. The bill is doing really well. The current bills are shown here. HR 2144 is the bill that's in the House of Representatives, and S 1450 is the companion Senate bill. I want to give you a little bit of history on these bills and how they got to where they are today, and also tell you about what's in the bill. So this is really sort of the 3 bullet points I would want to say about the bill if you were going to know 3 things about it and what it does and what it's intended to do. It's intended to promote access to care, to modernize Medicare by providing status, as I said, to genetic counselors so that their services can be delivered to Medicare beneficiaries. Currently, the only way genetic counselors can provide services to Medicare beneficiaries is when they're providing them incident to a physician who would be billing for those services. And that during the pandemic is something that has been particularly problematic. As we moved to telehealth, we had an army of genetic counselors who were ready and willing to provide their services by telehealth. We have a lot of data to say that genetic counseling, when provided by telehealth, can be done just as effectively. But billing and reimbursement was the barrier. And so as a result, during the pandemic, we had particularly strong access issues that we were facing. Quality. There's significant research, and I think Colleen touched on this, to say that genetic counselors have high competency in identifying the right test for patients. And it's gotten to the point even now where there are many hospitals across the country who are employing genetic counselors to review test orders flowing through those systems in sort of a utilization management role in order to prevent unnecessary testing, and particularly in cases where the hospitals are the ones who are paying for the tests and then billing in a pass-through manner, protecting the hospitals from liability of that. And then the other detail to the bill is that it establishes how genetic counselors would be paid. And the proposal currently in the bill is that genetic counselors would bill on the physician fee schedule at 85% of the physician rate. And this is something that's been done in other allied health professions and has allowed the bills to save money. So the prediction is that this bill will save money both because of this clause and because of genetic counselors and the data around genetic counselors' ability to appropriately order tests. Important things that this bill does not do is it doesn't take away or infringe on any other provider's scope of practice. In fact, scope of practice is not any part of the federal bill. It's about billing and reimbursement. Scope of practice is set by state licensure laws. So it wouldn't prevent anyone else from providing these services. And in fact, currently genetic counseling services are covered under Medicare. And it's just not when they're provided by genetic counselors who are not recognized providers. So history of the bill was first introduced in 2018 at the end of that legislative session, sort of a month before the session ended, and was really done as a way to socialize the bill, to start introducing it to folks in DC, and to go into 2019 having already introduced the bill and say that it was a reintroduction in 2019. So the bill was reintroduced into the House of Representatives in 2019. Over the course of the last congressional session, we had 21 co-sponsors sign on, strong bipartisan support. It was about evenly split, 50-50 among the co-sponsors, among Democrats and Republicans supporting the bill. But it got really challenging during COVID to fight for airtime. There was a lot going on, particularly throughout 2020 in the government, and we though our community was specifically impacted by the pandemic, I think many communities were impacted by the pandemic. So we reintroduced the House bill in 2021, and then for the first time introduced a Senate companion bill. And the national strategy around these bills for this current congressional Senate session was, as we've done, introduce both bills, and then to really focus hard on building congressional co-sponsors for the bills. We've also been recruiting additional organizations to support the bills, working on committees that are in a position to really advance the bill before, talking to congressional offices and Ways and Means Committee, working towards a budget, congressional budget office score for the bill. As I said, we believe it will save Medicare dollars when passed, which will also really help it pass. And then looking at the landscape of other legislative packages that are moving forward in the oncology space, in the rare disease space, in the telehealth space, places where this bill could be put into a package to be passed forward. And then working with the executive office as well for their support. So how are we doing? It's been a really great 9 months. So in the first 9 months of this session, we have recruited 24 co-sponsors in the House, again, bipartisan support from both Democrats and Republicans, and you see the list here. And our Senate bill has a bipartisan co-leads, Senator John Barrasso and John Tester, and so far we've had 2 co-sponsors sign on in support of the Senate bill. We, on our efforts to recruit organizations that support the bill, now have over 300 organizations supporting our bill. And what's even more remarkable, I think, than the number of organizations supporting the bill is the diversity of organizations supporting the bill. So it's hospital organizations, it's patient advocacy organizations, it's other healthcare provider organizations, physician organizations, laboratories, really across the space, across the landscape. There is widespread support for this bill and for genetic counselors and for access to genetic counselors. And I think really for me, the true north is the number of patient advocacy organizations that have signed on this bill, because that's ultimately what this bill is really about. I am going to briefly pass it back to Colleen because I wanted you all to hear a little bit specifically about what's been happening in Iowa and with the offices in Iowa.
Great. Thank you, Jillian. It's so exciting to hear about this bill. So we are so proud that Representative Axne is a co-sponsor. She actually co-sponsored in the last session as well and signed on pretty quickly this year when the bill was introduced. We've had meetings, genetic counselors in the state have had meetings with Representative Hinson and Miller Meeks, as well as, I believe, Fenstra's office. We know Hinson and Fenstra both voted in favor of our state licensure bill when they were in the state House and Senate. And so we're hoping that they'll also be supportive of our federal effort, but they have not yet signed on in support. And then we've also had meetings with Senator Grassley and Ernst's office as well. UI Healthcare has recently sent a letter to the entire delegation expressing that their strong support of this bill and the value this bill will bring our patients. And if any other organizations are interested in doing that, we're happy to help. I do want, Jillian mentioned the organizations that have signed on, and I do want to take a moment to thank the Iowa Oncology Society, Mercy One, Des Moines Medical Center, and UI Healthcare for signing on in support of the bill. Whenever we reach out to any of these offices, we point out all the Iowa organizations that are supportive of the bill. And so we're really excited for that as well. All right, turn it back to you, Jillian.
Thank you. So really my last slide is just, to ask for your help. And there are a number of different ways to get involved. There's a link in here to NSGC's federal advocacy page. If you just Google NSGC and federal advocacy, and we can post it in the chat too as well, you will get to a whole list of things you can do. And I think the key things that we can use help from other communities with are signing on to letters. And there's a link on this page where all you have to do in like 2 or 3 clicks is send a letter to your representative. And it's sort of a highly automated process. It goes through a particular process. So like at a minimum, couple clicks and you've sent a letter in. You can also write a personal letter into your representatives and share your own story or how genetic counselors have either impacted your care or the care of your patients, or how you wish they would if you had more access to them, is also a fine approach to take. We are always recruiting folks to join us on meetings with congressional staff. I spent a day on the Hill before the pandemic, and we had an individual who had early onset colon cancer and was found to have a genetic mutation in his family. and had a genetic counselor who drove all over the state collecting samples from his family, identified a number of family members who were at risk, who immediately had colonoscopies, and in whom their cancer was identified early. And he says, she may have saved their lives. But his story was a really, really powerful one for lawmakers. And I think if there are folks out there involved in patient advocacy efforts, we would love your help, because as I said, I think these are the stories that are the true north for the bill. And then additionally, if you're a part of an organization that hasn't yet signed on, but you think they might want to, there's a sign-on letter on this website for, and Colleen posted it in the chat. So you can add your organization to the sign-on letter. All you have to do is sort of send an email and say, we'd like to be added, and you'll be added to that. We'd love to have more names there. So that's what I had for today. Like I said, it's been such a pleasure to be with you today. I'm a big fan of Iowa. I've been out there twice, mostly just to visit Colleen. But it's nice to be there virtually today, nonetheless. So thank you all.
All right, well, Jillian and Colleen, thank you guys so much. If anyone has any additional questions, we have a couple minutes here. Please put them in the chat. And Colleen, I believe Unity Point did sign on, but if you're not seeing us, then something didn't go right. So let me know.
Okay.
It might have been kind of recently, so.
Okay, thank you.
Yeah.
I will definitely look and add you to the list and notify our delegation of that update.
You're good.
And I think, to Jillian's point with Representative Axne, one of the things that she realized was at the time, there was actually only one genetic counselor in Des Moines actually working with Dr. Deming. And that was her district was so underserved and actually would benefit more, I think, the most from this bill. And that was where she became a co-sponsor really quickly, recognizing how this would help the patients in her district.
You guys are doing really important work. I can speak firsthand that we had been working to recruit genetic counselors for a couple of years, and we finally have 2, and we're super excited, and they're great. And also we've recruited some genetic counseling assistants a couple times now because they keep getting into school, which is great. But a lot of really good candidates out there looking to go into the profession. I think it speaks a lot to the really important work you do. So thank you guys so much.
Yeah, thank you, Sarah.
All right, well, it doesn't look like we have any other questions at the moment, but thank you all for your time. We really appreciate it. Everyone who joined, make sure you check the chat for information about evaluations, and hopefully we'll see you all tomorrow for day 3.